Hi Venus, I'm back here with some stuff related to general pathology. So, before going into this topic, as we are humans, every day we have challenges, every day we have surprises. Can be a positive one or can be a negative one. But you always should follow this theory. The challenges are not supposed to paralyze you, they are supposed to help you to discover who you are, what you are capable of. When you get a challenge in front of you, then you will know the real capability of yourself. Only when you have tough tasks in front of you, and if you achieve them, you will really get to know what you are to the people around you. So now, if you have any challenge in front of you, that can be personal or professional, let's take it. Let's fight for it. Let's achieve it. Then you will show yourself to the world what you are here for. So please try to implement all these good aspects in your preparation. So coming to today's topic, that is cell injury. So cell injury is something like the traumatic injury for us. Like when you have a stimulus, something like a stress, and when you are not able to bear the stress, then you will start adapting to the stress. Even when the stress is too increased, even then after adapting the stress is increased, then you may cause some reversible damage. And even then, if it is more of intensity, then it may lead to some irreversible damage. This is something similar like the situation to the human life. So cell injuries can be basically due to modification in the internal or in the external environment, but the cell responds to the stress. So the cell responds to the external stress or the internal stress by the host factors or by the factors of the agent which is causing the stress. So either can a stress or can a pathological stimulus lead to following changes in the cell. The change one is the adaptation. The change two is a irreversible or a reversible damage. And the end, it may lead to the death of the cell. So these are the changes which are based upon the intensity or the duration of the stimulus, that can be physiological or a pathological. So what happens in cell injury? So when the cells are getting injured, there will be damage to the mitochondria. As you know that the mitochondria is called as powerhouse of the cell, which generates the ATP. So whenever there is no mitochondria, there will be drop in the ATP. So whenever there is drop in the ATP, okay, and lysis of the mitochondria, most of the cell contents which are present in the mitochondria, they leaches outside. So whenever there is drop in ATP or drop in the oxygen levels, the cell leads to anaerobic and further leads to damage by the release of the free radicals. As you know, I have already discussed about the reversible, irreversible cell injuries, right? So reversible type, reversible. How you can identify reversible, irreversible by seeing under microscope? This is the most commonly asked question. Which of the following is irreversible cell damage? Which of the following seen in reversible cell damage? So simple logical explanation, simple way to handle the things is intensity. Means normal cell will become worst in reversible injury and will become too worst in irreversible injury. Intensity varies. The second one, easy to remember, in most of the cases, your reversible swelling, your reversible cell injury, there will be swelling. Okay, there will be swelling of all the organelles. You can see the mitochondria. The mitochondria, there is swelling. You can see in the cell membrane there is swelling, and you can see in the rough endoplasmic reticulum or ribosomes there is swelling. Okay, and next one is irreversible. So irreversible damage is of more intensity. In most of the cases it will be disturbed or disorganized. You can see there will be apart from swelling which is there in reversible, there will be lots of large densities accumulation. Okay, large densities of the bodies are accumulated. You can see these vacuoles and the large density of the bodies that are accumulated. You can see there is disruption of the cell membrane. Apart from lysis, which is of severe case, there will be dispersed ribosomes. The ribosomes are disorganized. Okay, so all these are the basic differences you have to learn. The next comes, it goes the same. Okay, you will have disturbed, you will have ruptured, and of course these three terms are very, very important in examination point of view, because we have seen n number of questions in these areas and the questions were asked recently. Pinacosis, okay, is condensed form. Okay, you can see the nuclear material is condensed. Okay, is condensed. Hexes is fragmentation. You can see so many fragments of nuclear membrane. And of course, you know the meaning of lysis, which ruptures and the material will get lysis or something called as dissolution. Okay, so please do make a note about these three terms, which are very, very important. The next comes is the cell injury, right? The cell injury. Cell injury can be either physical, the etiology can be physical, the etiology can be chemical, okay, physical, chemical, or can be infections. Few infections lead to cell injury, and in few cases it can be genetic because of genes also. Okay, so these are the primary four causes for different categories of cell injury, but the most common cause of cell injury is hypoxia. Okay, as everyone knows, the most common cause of cell injury is hypoxia. Hypoxia means, hypo means less, oxia means oxygen, less oxygen. Okay, less oxygen. Whenever you have less oxygen, what is going to happen? So this can be given as a flowchart based question for you. Okay, so whenever you have less oxygen, there will be decreasing in the ATP generation. Okay, there will be decreasing in the ATP generation. So what happens when there is decreasing in the ATP generation? Either the calcium which is present outside will increase, that is cytosolic calcium will increase, or when the ATP is dropped down, there will be more oxygen free radicals available in the cell, or the ATP is generation for synthesis of phospholipids. The synthesis of phospholipids will decrease, because phospholipids are the primary contents of your cell membrane, of all the cell membranes. Whenever there is a decreasing in the phospholipids, there will be no membranes. So when there is decreasing in the synthesis of phospholipids, okay, so there will be no proper membrane formation on the cell, because phospholipid is the primary content. That leads to cell membrane damage. Okay, so that is one side, right? The second side, when there is increasing in the cytoplasmic calcium levels, these cytoplasmic calcium levels will cause increasing in the calcium in the mitochondria. So most of your pathological changes or cell injuries are associated with an ion. This is again a question. Ion, which is responsible for most of the cell injuries or any type of cell injury, is primarily the calcium. The answer for this is calcium. So whenever you have increasing in the cytoplasmic calcium levels as well as mitochondrial calcium levels, this calcium is going to activate phospholipidase enzyme, or it's going to activate protease enzymes. It's going to activate all the enzymes. So whenever these enzymes are active, is going to activate, protease enzyme is going to break the protein structures. Phospholipidase is going to break the phospholipid. So it's going to break and cause damage to the membrane, cause damage to the lipid production, cause damage to the cytoskeleton, leading to the cell membrane damage. As already discussed, that whenever there is oxygen radicals, okay, so oxygen radicals are going to cause damage to the DNA as well as the lipid peroxidase, leading to the cell membrane damage. So finally, the end product of hypoxia is, after lots of pathophysiological changes, it leads to membrane damage. So that membrane damage can be any of areas. So whenever the membrane is damaged, all these enzymes which are present inside the cells are going to come out, and there will be increasing in the serum enzyme estimation. Okay, so most of the enzymes, serum enzyme estimation can be done. Most of the enzymes, they increase because there will be liberation of intracellular enzymes. Okay, so they may lead to the cell death because the membrane is damaged, the cellular death, or the nuclear membrane is damaged, there will be the nuclear changes. This is the basic pathophysiology, outline pathophysiology of hypoxia. The next comes is, as I was telling, that adaptation. Okay, the first change for stress to the cell is adaptation. So all these categories, they comes under adaptation. One is atrophy. Okay, one is atrophy. Second one is hypertrophy. Hypertrophy means there will be increasing in the size of the cell. Hyperplasia, there will be increasing in the number of cells. Okay, metaplasia, there will be change in the shape of the cell. Okay, you can see this is a normal cell. Because of some stimulus, there is changing in the type and the shape of the cell. That is called as metaplasia. And of course, you know this dysplastic changes or dysplasia. Okay, few examples you have to make a note. Regularly, they may ask you simple definition of what is hypertrophy, what is hyperplasia, but they may ask an example based questions. Okay, so these are the examples which have a little bit of controversy, but you need to conclude with these answers. So regularly, a pregnancy uterus comes under which category? Okay, it comes under hypertrophy. It has hyperplasia, but it is very, very minimal hypertrophy. Okay, the breast tissue of a woman during pregnancy and puberty, okay, it comes both, okay, sorry, it's not drug, it is during pregnancy and puberty, it comes both. Okay, it is an example of both hypertrophy as well as hyperplasia. But if you are talking only about the lactating tissue of a breast during the pregnancy or post pregnancy, it is only hypertrophy. So please do make a note about 3 examples, because these are the examples which are regularly asked as a controversial things. Rest all, I hope you can easily manage. The next comes is, I was stressing you more that, okay, these are the common sequences, right? So metaplasia is the exchange of normal epithelium for other epithelium. Okay, and preferably the key word is it is reversible, because means once the stimulus is given, it is something like your reversible pulpitis. Once the stimulus is given, there will be pulpitis. Once the stimulus is removed, there will be, it reverts back to the normal condition. Means once the stimulus is there, the epithelium changes to a different type. Once the stimulus is removed, the epithelium comes back to the, so it is called as reversible. Metaplasia is called as reversible. So some key points and notes is that you need to add related to metaplasia. Metaplasia is something like a normal cell, okay, modifies into a different cell. This is called as metaplasia. If a cell converts like this to this, this is also called as metaplasia, but it is basically reversible, means it reverses back after the removal of the stimulus, similarly like your reversible pulpitis. So key points to be added. Point 1, metaplasia is thought to arise by reprogramming of stem cells to differentiate along a new pathway rather than a phenotypic change of already differentiated cells. Okay, the key word in this is reprogramming of the stem cells. Is a question which was previously asked. Okay, and it's a direct line that is taken from the textbook. Okay, so reprogramming of the stem cells is nothing but is nothing but the metaplasia. And of course, it's a question that is asked in few exams, that is, it's a reversible condition. Okay, so what happens if metaplasia stimulus is for longer duration of time? For example, your reversible pulpitis stimulus is for longer duration of time, then it will be converted into irreversible pulpitis. So if the stimulus is of longer duration of time, it is going to convert it into the next level, that is dysplasia. And there are two types of metaplasias. One is epithelial and mesenchymal. But if you compare the conditions, epithelial metaplasias are more common. Epithelial metaplasias are more common. Out of epithelial metaplasias, columnar cell converted into squamous cell is more common. Okay, regularly they may ask you which is most common. Epithelial metaplasias are most common. In epithelial metaplasias, the conversion of a columnar cell to that of the squamous cell is the most common. Okay, so we'll learn some examples which are mainly concerned or mainly asked for the dental students. Okay, so as already told, there are two types of metaplasias. One is epithelial and mesenchymal. So coming to the epithelial metaplasia, okay, so regularly occurrence of this epithelial metaplasia, like the squamous changes, okay, that occur in the respiratory epithelium of the smokers. Okay, respiratory epithelium of the smokers. Normally, you will have your columnar epithelium with the cilia in the respiratory system, but due to smoking, this is going to convert it into squamous epithelium. Okay, the columnar epithelium is going to convert into squamous epithelium. Okay, so that's an important example of a person who is smoking. Okay, so you can see here the normal bronchial epithelium. So the normal bronchial epithelium is columnar epithelium with the cilia, which is going to convert it into the squamous epithelium after a few days, and which is further going to convert it into carcinoma, that is with the dysplastic changes. This is the best example of squamous metaplasia. So other example of squamous metaplasia, I will be having some textbook reading related to this slide, is vitamin A related stuff. That can be either deficiency or excess of vitamin A lead to squamous metaplasia, either excess or deficiency, because this is again a most commonly asked question related to your vitamins. Which vitamin deficiency or excess may causes metaplasia or squamous metaplasia? The answer is vitamin A. And of course, we have learned, okay, that is Barrett's esophagus. So Barrett's esophagus, regularly in the esophagus, okay. So in the esophagus, you have your squamous epithelium. Okay, you have your squamous epithelium. But due to secretion of acids, the squamous epithelium is being replaced by the columnar epithelium. Okay, so you can see this is a biopsy of a lower, okay, particularly this is again a question. Lower half of the esophagus only will show this Barrett's esophagus. With a chronic GRT, it shows columnar epithelium, that is columnar metaplasia, which is called as Barrett's esophagus, and of course it contains the globulate cells. Okay, so regularly what is the epithelium? The squamous epithelium is typically of normal esophagus. Regularly we used to have squamous epithelium, but due to acid secretion in that area, to protect the cells from the acid secretion, because globulate cells are the responsible for secretion of mucus and which acts as a protection from acid, so the squamous epithelium, which is originally, will be converted into the columnar epithelium. So this is the best example. You can see this is the lower part of the esophagus, regularly lined by the squamous epithelium, but due to acid secretion, to protect the cells, this has been replaced by the columnar epithelium. And this area of lower esophagus, which has been replaced from the squamous epithelium to the columnar epithelium, is called as Barrett's esophagus. And the same goes with many other areas. Okay, so there are many other areas. Your urinary bladder is again an example of the squamous metaplasia. Okay, so squamous metaplasia, anyway, we'll have a textbook reading of examples. They may not go very deep into the concept things. Maybe they may ask a depth-oriented question related to Barrett's esophagus, okay, or maybe epithelium of the metaplasia they can ask, but mostly they may not ask you the urinary system, okay. But most of these metaplasias will lead to carcinomas in the future, okay. It can be your Barrett's esophagus, which will be converted into high risk of converting into adenocarcinoma of esophagus, or you can see this particular type of metaplasia which can lead to squamous cell carcinoma in future. So as already said, like epithelial metaplasia, and the second one is mesenchymal metaplasia. Epithelial metaplasias are more common, okay. So in epithelial metaplasia you have squamous metaplasia and columnar metaplasia, okay. So squamous metaplasia is, the example is chronic smokers, okay, and if you want you can add this vitamin A deficiency or excess may lead to squamous metaplasia, okay. So that's again a most commonly asked question for the dental students, okay. And if you want you can add this uterine, okay. You can add this squamous metaplasia can be seen in uterine endocervix, particularly in the case of prolapse or in the old individuals. It is going to get replaced. Originally it is lined by simple columnar epithelium. Later it is going to replaced by the squamous epithelium. The next comes is the columnar metaplasia. Okay, when compared to squamous metaplasia, the columnar metaplasia is going to be less common. So the best examples of columnar metaplasia are, yes, I have already discussed, that is the Barrett's esophagus. Okay, the Barrett's esophagus is one. Smoking, it is squamous metaplasia, whereas chronic bronchitis is a columnar metaplasia. Okay, so if you want you can add these examples, but the highlighted one are the most commonly asked questions. The next one, we are done with the epithelial metaplasias. The next part is mesenchymal metaplasias. Okay, the mesenchymal metaplasias are of two types. One is osseous metaplasia and cartilaginous metaplasias. So if you want you can add these examples to your notes. They can be given as a questions. So next level of metaplasia is already discussed, that is dysplasia. Dysplasia clearly gives disorganized cell development is called as dysplasia. Sometimes it is also called as atypical hyperplasia. Hyperplasia we know, but hyperplasia is an organized one, but here it is atypical hyperplasia. It's not normal hyperplasia, it is an abnormal hyperplasia. And of course the characteristic features that are seen in the cells or in the epithelium are very, very important. There will be increasing in the number of layers of epithelium, the number of cells increase, the number of layers increase. Disorganized arrangement of cells from the basal layer to the superficial layer can be seen. Loss of basal polarity, of course you know this is a trademark feature of carcinoma. Loss of basal polarity means the nucleus move away from the basement membrane. Okay, there will be cellular and nuclear pleomorphism. Different nucleus, different cells are of different shape, different nucleus is of different shape. Of course this is a star trademark question. Okay, in dysplastic features there will be increasing in the nuclear cytoplasm ratio. There will be nuclear hypochromatism, different strains for different nucleus of different cells, increasing in the mitotic activity. So all these are the features which are seen in the dysplastic cells, and it is a very, very important area to be focused. The next comes is the difference between the metaplasia and dysplasia. You have learned so much related to metaplasia and dysplasia. Now just make a note about difference. Metaplasia is reversible. Metaplasia is change from one cell to other type of cell, whereas dysplasia is the extension of metaplasia. When your stimulus is extended more, then it will be dysplasia. Okay, so the simple definition, change of one cell epithelium or mesenchymal cell to other cell is called as metaplasia. Disorganized cell development may be accompanied after hyperplasia or metaplasia is called as dysplasia. Metaplasia is of two types, that is epithelial metaplasia and mesenchymal metaplasia. Epithelial metaplasia is more common when compared to the mesenchymal metaplasia, whereas dysplasia is only epithelial type. There is no mesenchymal type, only epithelial type. Tissues most commonly affected. You can write down the examples. Okay. The next one, cellular changes. There will be matured cellular development. Okay, here everything is disorganized cell development, pleomorphism, nuclear hypochromatism, mitosis, loss of basal polarity, all are disorganized. Here they're well organized because they're giving a try to save the system, right? So it's reversible. Once the stimulus is removed, it is reversible. Okay, so it will progress to the next level. I think these are the simple differences, okay, which are very, very important in examination point of view. The next comes, I'm going to talk about necrosis. In detail, we'll have some rapid fire and discussion in our respective groups, but this is completely a solidly textbook based analysis. So simple, I hope you know the definition. Necrosis can be defined as localized area of death of tissue followed by disintegration of cells by hydrolytic enzymes. That is important. Hydrolytic is important. So there are 5 types of course, there are even special types of necrosis, but there are 5 types of necrosis. That is the coagulative necrosis, liquefaction necrosis, caseous necrosis, fat necrosis, fibrinoid necrosis. So out of which the coagulative necrosis is the most common type of necrosis is coagulative necrosis. Okay, the most common type of necrosis, followed by irreversible focal injury, most commonly due to hypoxia. This coagulative necrosis is most commonly due to hypoxia, that is the cell injury. Okay, and it is less often because of bacteria or the chemical agents. It's most often due to hypoxia. The organs which are affected by this are heart, kidney, and spleen. Okay, so this example is very, very important. Heart, kidney, and spleen. Next one is the liquefaction necrosis. So liquefaction necrosis occurs most commonly by an ischemic injury or bacterial or fungal infection, converted into a semi-solid fluid-like material. And you can write down the examples. That is the brain, infraction of a brain and abscess cavity are the best example of liquefaction necrosis. Next one is caseous necrosis. So caseous necrosis you can most commonly see in the case of tuberculosis. We'll learn about that. Okay, you'll learn how soft tubercle, hard tubercle, what is the difference between soft and hard tubercle. All these are regularly asked questions in your UG as well as in the entrance examination. So caseous necrosis is most commonly related to the TB, and it is a combination of both coagulative and liquefaction necrosis. The next comes is the fat necrosis. Means fat necrosis occurs in the tissues or in the bodies or in the areas where there is more fat. So it's a special form of cell death which is mainly concerned with fat-rich anatomical areas. One is traumatic fat necrosis of the breast, because the breast is an area of more amount of fat. Okay, and pancreatic, acute pancreas, you can see fat necrosis. So breast necrosis and fat pancreatic, acute pancreasis are the best example of fat necrosis. The last comes is fibrinoid. Fibrinoid is something like a material. It's more like a material. Fibrinoid is characterized by deposition of fibrin-like material, which has the staining properties of fibrin. Okay, so where does they come? Most of the immune complex mediated reactions like autoimmune diseases, all these diseases, hypertension and peptic ulcer are the examples of the fibroid necrosis. Most commonly, they will ask you the examples of each type of necrosis as a question. The next comes, we are done with the necrosis. Okay, I'll be posting another video related to apoptosis. Okay, the sequence of the events that takes place, a video will be posted immediately. But this is the basic difference between the necrosis and apoptosis. Apoptosis is a programmed cell death. It's made programmed cell death, whereas this is a disintegration by hydrolytic enzymes. Okay, the causative, the most common cause for necrosis, as of course the coagulative necrosis, is hypoxia. Whereas here it can be due to a pathological change or a physiological change which leads to the programmed cell death. Okay, so morphological differences are most important. Whereas in the necrosis, you can see inflammation is present. Whereas apoptosis is a programmed one. There is no inflammation. There is no activation of inflammation. In necrosis, there will be death of adjacent cells also, which are surrounding, but there will be death of only single cell, which is programmed. The programmed cell only dies. There will be cell shrinkage here, whereas in the necrosis, because of inflammation and everything, edema and every formation, there will be cell swelling initially. Okay, there will be cytoplasmic blebs on the membrane, which leads to the breakage, right? And here the cytoplasm is totally disturbed. There it is just we'll have blebs. So you can see apoptotic bodies can be seen. Here damaged cell organelles can be seen. Here the nuclear membrane or the nuclear material is condensed. Here it is totally disturbed. Phagocytosis of the apoptotic bodies occurs by macrophages here. Okay, here the debris is removed by the macrophages. So molecular changes are already discussed, because I'll be discussing all these changes in another video. Please do have a quick look over these differences, which can be asked as a question for you. So the next comes is the gangrene. Okay, you need to learn something about gangrene. There are two types of pathological changes. One is gangrene, and second one is pathological calcification. Okay, so we'll try to learn about the basic definition of gangrene, some pathophysiological changes in the gangrene, and types of gangrenes. So gangrene is a necrosis of a tissue associated with superadded putrefaction, most commonly followed by coagulative necrosis. Means lack of blood supply. It's just an extension of the necrosis, the process, the coagulative necrosis process. Okay, so this putrefaction can be primarily initiated by the bacteria, which can resulting in massive tissue necrosis. So there are different types of example. Even your Noma, Cancromoris, and everything comes under gangrenous stomatitis around the mouth. There is something called as gangrenous appendicitis. So all these comes under gangrene. Like it's necrosis followed by necrosis. The bacterial addition will lead to the putrefaction of that particular area, lead to the formation of a gangrene. So coming to the dry gangrene. Okay, dry gangrene, this is a form of gangrene which begins in the distal part of the limb, which is most commonly seen in the distal part of the limb. And the very important aspect about this dry gangrene, there will be line of demarcation. Okay, a line of demarcation is formed at the point between the gangrenous part and the viable part. You can see the line of demarcation. Okay, and you can see some black color, right? This black color is basically due to hydrogen disulfide. The hydrogen disulfide produced by the bacteria will react with the iron that is present in the blood to form iron sulfide, which is dark in color. Okay, the next comes is the wet gangrene. Wet gangrene occurs naturally in the moist tissues and organs such as bowel, or organs such as lungs, mouth, cervix, and everything. Okay, the two other examples of wet gangrene clinically are diabetic foot. In diabetes, you can see both wet as well as dry, but diabetic foot exclusively is a wet gangrene example. So this wet gangrene is basically due to high glucose content, okay, which allows the growth of bacteria. So bacteria will grow, because at the end, after necrosis, gangrene is something like which allows the bacteria to grow in that particular area. And you can see bed spores, the patient who are like bedridden for a longer duration of time due to the pressure on the sites like sacrum, buttock, and heel. There is chances of occurrence of wet gangrene. So wet gangrene develops basically due to the blockage of the venous returns. Okay, due to the blockage of the venous returns. Okay, so, and followed by the wet gangrene. Okay, the next comes is the gas gangrene. The third one is gas gangrene. Gas gangrene is a special type of wet gangrene. It's again it's a wet gangrene, but special type of wet gangrene which is produced only by the gas forming bacteria. This gas forming bacteria, the best example is Clostridium. Okay, so I hope you remember your gas gangrene in your general surgery also, right? So gas gangrene is mainly concerned with the Clostridium. So they can ask you, first one is dry, second one is wet, and third one is gas. Gas is nothing but it's a type of wet gangrene. So the most common site, the most commonly seen in the limbs and extremities. It is most commonly seen in the wet areas, that is bowel. Okay, so it's most commonly due to the arterial occlusion. It's most commonly due to occlusion of both, mainly by the venous returns, blockage of the venous returns. Macroscopically, the organ is dry, shrunken, and black. Here, the organ is moist, soft, swollen, rotten, dark. Both are dark. Here it is black, here it is dark. Putrefaction is limited to a very little blood supply. It's limited due to a very little blood supply. Is marked due to snuffing of organ with the blood. And if you see the line of demarcation present, clearly present, no clear line of demarcation in the case of wet gangrene. Bacteria fail to survive in this area because of lack of oxygen or limitations of the supply of blood. Here, the bacteria will be numerous. Okay, so this particular note was added basing upon talking about the diabetic things more in concern, because I've seen many questions related to diabetic gangrene. Okay, so gangrene. The foot is the most common location for tissue necrosis. Okay, the foot is the most common location for occurrence of the gangrene, and foot gangrene is 50 times more prevalent in diabetics compared with non-diabetics individual. More chances that too, particularly above 40 year of age. So they can ask you a case-based question. Okay, a patient with this necrosis of the foot, they may give you an age of over 40 years or 50 years. So the diagnosis is a diabetic foot, or the patient is diagnosed with the diabetes, because they have more chances of occurrence of the diabetic foot. Okay, while the dry form is caused by the dry form, that is dry gangrene form, is caused by the large vessels blockage due to sclerosis. Dry is due to sclerosis. Okay, dry is due to the sclerosis, because we have already learned dry is basically due to arterial occlusion. And wet is believed to be a late manifestation. Wet is believed to be a late manifestation of microangiopathies. I hope you remember the diabetic complications, like after which is one of which is angiopathies, microangiopathies. So diabetic patients will have both dry as well as wet. If they ask in specific, go for the wet because it's a late complication. But you can see dry gangrene in diabetic patient also, but dry gangrene in diabetic patient is mainly due to the sclerosis. Both may occur in diabetics, but a small vessel disease is more common, and it's directly associated with the diabetic vascular dearrangements. Dry gangrenes occurs mostly in diabetic patients with sclerosis, whereas wet gangrenes develop basically as a late complication. Okay, so if they specifically ask diabetic foot, go for wet gangrene. If they ask diabetic, there are chances that both dry as well as wet can be seen. But if they ask the etiology of wet gangrene diabetic patient, the answer is sclerosis. Okay, the answer is sclerosis. And wet gangrene, it's normal. Okay, so please do make a note about these difference, because this is an area of controversy again. So last but not the least is calcifications. I hope you're very good at calcifications. So regularly what they do is they may ask you the difference between metastatic and dystrophic calcification. So easy to remember, dystrophic has D word. Okay, so it is D and A. So dystrophic calcifications are the calcifications which are occurring in the dead and degenerated. Okay, when an individual is dead, when the individual is not working, the calcium metabolism is normal. When the calcium metabolism is normal, the serum levels of the calcium are normal. Everything is normal. And when the individual or a cell is dead, it is generally irreversible. So all are interlinked. Dystrophic can be seen in dead and degenerated. Dystrophic is seen when the calcium metabolism is normal, when the serum levels of the calcium is normal. As it is seen in the dead and degenerated, it is irreversible. You cannot make a dead cell normal, right? So that is dystrophic calcification. So remember only dystrophic. Metastatic is opposite. So metastatic calcification can be seen in normal tissues. There will be dearranged, disorganized, or changed calcium metabolism. There will be increasing in the calcium levels, and probably it will be reversible. So all dead and degenerated examples will come under dystrophic. Very easy. Dead and degenerated, because already said it is dead and degenerated. All live examples. Okay, you can see adenoma is a live cell. Okay, you can see hypervitaminosis D is a live cell. Metastatic carcinoma is a live one. So most of these syndromes and everything are live ones. Whereas you can see here, all are dead parasites, infracts dead, necrosis dead, thrombi dead, certain tumors which are dead. So most of the examples, easy to identify the examples, most of the dystrophic examples are dead examples, and most of the metastatic examples are conditional examples, which are live cells. So apart from this, I just want to add a note about our dental related stuff related to this calcification. So of course I hope you remember your pulp stones, the different types of pulp stones, true pulp stones, false. Anyway, we're going to learn this either in the histology or either in the endodontics. But there will be some pulp cells which are dead. Okay, so when there is accumulation of calcium in these pulp cells which are dead, as already discussed, dystrophic calcification is seen in the dead and degenerated. When some pulp cells are dead, the calcifications that occurs in those pulp cells are called as dystrophic calcifications, which are nothing but pulp stones. Okay, which are nothing but pulp stones. How you can see them? They are nodular, calcified masses. They can be seen either in the coronal part or in the radicular part. Okay, and they develop into tooth that appears quite normal in their architecture externally, but on radiograph you can see this dystrophic or calcifications of the pulp stones. Okay, the next comes is a little bit application part of the pulp related necrosis. So in most of the cases, the pulpal necrosis is coagulative necrosis because lack of blood supply or damage to the blood supply or trauma to the blood supply. Because if you see Ellis class 4, which is a necrotic pulp due to trauma, Ellis class 4 is a necrotic pulp due to trauma, is basically due to the loss of blood supply. The blood supply is lost. Whenever the blood supply is lost, there will be hypoxia that causes coagulative necrosis. But pulp shows both the types of necrosis, that is liquefaction and coagulative, but most common is the coagulative necrosis. Yes, thank you, Venus. I'll try my best to post another video related to the mechanism of apoptosis, because I feel like that is the most trickiest area in this particular zone. Okay, stay positive, stay blessed, stay at home, work hard.